We have a very elite session of chairpersons. I would request Professor Mir Jamaluddin and Professor Mahbub Ali to remain on the stage, please, as you are on the chairpersons list. Sir, you are... And I would like to call Professor Fazlur Rahman, Professor Sayyid Ali Hassan, Professor Ikrem Reza to the stage, and the discussions are a galaxy of very renowned interventional cardiologists, Professor Sabina Hashem, Dr. Fatima Begum, Dr. Abdullah Al Jamil, Professor S.M. Mustafa Zaman, Dr. Mahbubur Rahman and Dr. Bijay. Please come to the stage and take your seat, please.
Hello.
Madam, can you hear us? Madam, please introduce your team and introduce the patient. Dr. Qayyum, we can see you. Dr. Qayyum, can you hear us?
Exactly. Amra ঠিক আছি।
Madam, can you hear us? Madam?
We are on. Madam, we are on. So, please.
Madam, can you hear us? Probably not.
I think আমরা বলতে পারি আমি ডক্টর ওখান থেকে ডক্টর বললো আমার থেকে দেখা
Madam, can you please introduce your team and your patient?
ওনারা কি আমাদের দেখছে? এখন তো শুনতে পাচ্ছেন? হ্যাঁ হ্যাঁ আমি রানা তোমার কথা শুনতে পাচ্ছি বাট ওই সাইডের কোনো কথা নেই ওর হিয়ার কথা শুনতে ওকে
Madam, can you hear us? Dr. Qayyum, can you hear me?
আমাদের সাউন্ডটা তো আসতেছে
Dr. Qayyum, can you hear us?
দেখেন তো শুনতে পাচ্ছেন এবার আমাদেরটা?
They can hear us but আমরা ওদের কথা শুনছি না।
আচ্ছা আপনাদের ওখানে কথা বলতে বলেন একটু।
There is some technical issues.
Can you hear us?
Yes, we can hear you.
Yes, so good morning. I mean, your voice is coming like from a very far off distance, something like that. So good morning, everyone.
They can hear us. So please start. Dr. Azam bolechen.
So good morning, and we are really happy to be part of this conference, and we have a live case today. So without further ado, let me introduce our team. So we've got quite a huge team: Dr. Qayyum, Moshed, then Russell, Tahir, Hamid, then Lipi, Pabon, Khairul, and Sister Mukta. And we've got two experts for the IVER. Shahin. Okay, great. So this is the crowd, a bit crowded. So we have a very interesting case. So without further ado, let us go to the case. Rana, can you show us the slides, please? Yes, so you all are aware about National Heart Foundation, which is a 480-bedded
Sound is not very clear, madam.
So we've been doing PCR on a regular basis since 1999, and at present we have done up till December of last year more than 60,000 PCIs. Next slide, please. And rota, the total number of rota is around 361. And can we go to the slide? So this patient that we will be talking about today is a 61-year-old female, and Rana, we seem to be losing the slide. So could you, yes, so it's a 61-year-old female who has chronic kidney disease with a serum creatinine of 1.7 anemic, with a hemoglobin of 9 grams, and she's hypertensive, diabetic. She has a long history of chronic coronary syndrome, and about 2 weeks back, her angina worsened, and she also had an episode of acute left ventricular failure. Can we, so this is a ECG. Now, 2 days back, can we go to the angiogram, please, now? Yes. So the angiogram is, as you can see, I think we've lost the, can you show the angiogram, please? So as you can see, there's a pretty significant disease in the LAD, and also angiographically we can see a lot of calcification in the LAD, and the diagonal is also diseased. And then this case was actually attempted, but in that center, rota was not available. So initially, after wiring, pre-dilatation was attempted. Can we go to the next slide, please? And pre-dilatation was actually attempted with 2.5 and also by 3 millimeter NC balloons, and the pressure, they went up to very high pressures, unable to crack the lesion. And the RCA is a non-dominant vessel, and it's diffusely diseased. So 2 to 3 days ago, PTCA was attempted, but as the lesion could not be cracked and the patient continued to have ongoing chest pain, today we are doing the case. Now, let's go to the next slide today. So what have we done so far? So we'll go live right now. Actually, we've just wired the vessel, done nothing up till now. So let's go live. Can you show the screen, please? Can you go to the screen, Rana? Live screen, please. Can you go to the live screen, Rana? Yes. So you can see angiographically there's a huge amount of calcium. This is.
We gone. Please wait a bit. We'll be connected again very shortly. Fellow colleagues and dignitaries, please keep silence in the room so that we can enjoy the session from National Heart Foundation. Please, delegates and fellow colleagues, please keep silence.
In the meantime, when we are on screen, please have your comments. Professor Mir Jamal, would you like to make any comment about this case? Or
Thank you, Professor Khalid Mohsin. Practically, it's a very difficult case. LED
Please play your
diffusely
attention,
calcified
please.
on the top of CKD.
Could not go further down. So
we are
up
back
to the point
online.
we were
Yeah.
able to
IVAS.
take the IVAS. We did some, took some pictures. The length of this lesion was 30 millimeters. So can we go to the IVAS now? And as you can see, there's a huge amount of superficial calcium to more than 270 degrees. And in some places, it was even 350 degrees. And the calcium and the calcified fibrotic lesion extends up almost to the ostia of the LAD. And also there's a significant dissection which was created in the proximal LAD due to the previous maneuver with the 3 millimeter NC balloon. So there's dissection, and we have been unable to cause the IVAS up to the distal part of our lesion. The left knee looks fine.
Audience, please
As we go proximally, this
focus
is a
your
dissecting
attention
flap,
to
as
the
you can
screen.
appreciate. So there's almost 360 degree superficial calcium as well as, and there's this dissecting flap. And then as you go more proximally, you see the calcium, and then in the proximal part of this is the circumflex, which is relatively free of any significant disease, which is good news. And this is the left main, which looks fine. So this is what we've done up till now. So she's got dissecting in the proximal part of her lesion. She's got significant calcific lesion, and already a previous attempt was made with NC balloons, and she's got ongoing chest pain. She's got CKD, she's anemic. So this is up till what we've done up till now. This is her MLA in the proximal part. So what's the MLA there? 1.28 millimeter squares. So pretty severe disease, right? So we took our So we go back to the live screen again, please. So what have we done up till now? So we've changed our wire, like we exchanged our pilot wire for this Ransu floppy wire initially. So we've changed with the help of a Fantos microcatheter, we've changed our wire to a rota wire just now, and we've removed the wire from the diagonal. So now we plan to do rota ablation. Obviously the challenges are, this is a very diffusely diseased, long segment disease. We've got dissection in the proximal part, but the fact of the matter is that this vessel, can you hear us, please?
Yes, madam, we can hear, but the sound is not very
You
clear.
can't hear us.
Sound is not clear. We are hearing, but we cannot understanding.
I think we'll start our rota. Even if they can't hear us, we'll just go on doing the procedure.
Madam, our audio is okay, but visually we are
So
not
if
okay.
someone has a phone, maybe we can tell to the phone what's happening. The phone and a micro might help. Microphone.
Oh, shut up.
They were not saying anything, so I thought they were. So we'll just go on doing the procedure. So we are taking a 1.5 rota burner.
Oh. For the younger generation, I want to know what is the vessel size distally.
Distally, we could not cross the lesion, but from what we crossed, we saw that the vessel was like 2.5, right? Can you show us the IVUS shoot again, please? Go to the IVUS, yes.
2.5
so
and distally vessel is 2.5, and that is why you have taken 1.5 1.5 rota bar.
And actually, the IVUS could not cross the entire lesion, right? It got stuck in the middle, and the place where it got stuck, that is where. So we've taken a rota bar.
With 1.5.
1.5, yes. And obviously, it's a bit of a challenge because there's some dissection in the proximal part. So we've taken a 1.5 bar. We're switching the dyna off. And now let's see, fingers crossed, how the vessel behaves with rota ablation. Obviously, dissecting a rota is not an ideal situation, but it's in the proximal part. Fluoro, please. I think we'll make it the catheter a bit more coaxial. Okay, right. So, yeah. টাইট করছে যে ঢুকতেছে So the proximal part of the lesion we just managed to crack, and as you see, we're giving small short runs, just doing a bit of pressure there, not exerting ourselves, taking our time, and it's a 180, Cathlab 80,000 rotations. So let's see, we'll gradually, hopefully crack the lesion with this rotation.
You have decided to bar with 1.5, and barring will be at the speed of 180,000.
Yes. So this part you're having problem,
speed.
right? Not going.
And for the younger colleague, you see how rota barring is done, pecking motion.
Yes, so we took a short run, again second run, and now we'll go more distally. Can you show the previous run? Yes. So as you can see, we go very, very gently, and yes, and now we have to.
And during barring will not stop in the lesion, mind it, for the younger colleagues.
So we've crossed the lesion which the IVUS catheter could not cross. Now we are going to, we are doing a polish run at 140.
Meet Jamal sir, whether
Yes.
you will advocate to do cutting balloon, to try cutting balloon before taking the rota.
So-
Now, rota, whenever we have decided, first of all, Madam showed that there is probably in the, I did not understand, probably in the previous setting, they used balloon and balloon was dog boned or balloon was not inflated. Balloon uninflated or dog boning effect of the balloon having IVUS findings with near about 360-degree calcification. What is the utility of cutting balloon before rota? If you do the use cutting balloon or if you make dissection, it will be horrible for rota. Then you will not be able to overcome with rota. If rota is not in your hand, you can try with cutting balloon.
No, in this case, that the area of severe stenosis with calcification is about 2.5. So why we will use rota here? We can use IVL.
But it is
It is
360.
1.3.
That is also
The minimal luminal area at the tightest point was 1.3, and we could not cross that. Distal to that, we could not even cross. The IVUS could not cross. So the minimal lumen area was 1.3.
Professor Fazila Malik, Professor Reza asked a question, why not IVL? Why rota? Why not IVL?
Well, you see, the problem was that we took our IVUS probe, right? We took our
IVL balloon is bulky.
IVUS probe, and IVUS probe did not go even. So the IVUS probe, when you cannot even cross your IVUS probe, it would be, I think, not worth the try to take an IVL because the IVL would not go. The Boston Scientific IVUS has the lowest profile possible, but it could not cross the lesion. It went up to
First of all-
1.3 millimeter area and then it got stuck there.
First-
So I don't think an IVL would have done the trick here. But of course, IVL is a good tool, especially in vessels where you can, it's a large sized vessel and you have deep calcium. If you have deep calcium, then IVL works well. But here, mostly the calcium is pretty diffuse in nature and it is superficial.
Yes, superficial calcification, usually rota is better.
Yes, for superficial calcium as well as for
And
nodular
deeper
calcium.
calcium, if I do
Nodular
OCT
calcium
and if I
also-
found that calcium is thick, meaning that more than 5 millimeter, 0.5 millimeter, then there is a good option for IVL. Even in this case, probably we can do IVL, provided the IVL balloon cross. As because the IVL balloon is a bit bulky, we shall have that lumen to cross the IVL balloon. And if the entire vessel is calcified, then it is very difficult to overcome by a single IVL balloon. As because proximally dia is 4, distally dia is 2.5. So we may require 2-3 IVL balloons. That is also limitation.
Another thing that I want to highlight here is that with rota, we also have the option to upgrade our wire, right, or the bird. So like if you want, if cost is a consideration, you can always go from 1.5 to a 1.75, or if you have a larger bore sheet, you can even go to 2 millimeters. So, I mean, that is there also available. You can upscale your rota bar if you feel that there is. Now we are taking a wire to the diagonal.
Is there any way to make the sound system clear? Madam, can you hear us?
Yes, we can hear you. I think I might need a micro. This diagonal
one to
also disease. We might need to take a micro to help us support taking the wire. Oh no, the wire went in. That's good.
Your patient is heavily calcified lesion with CKD.
With CKD with anemia. High. So high bleeding.
CKD, anemia.
Yes.
All are in favor of ultra low contrast angioplasty.
Yes, so I mean, we've hardly used any dye so far. We did the rota, didn't take us any dye. We've managed to wire the diagonal also, just used maybe 4 or 5. So we have not as yet used much dye. Of course, ultra low contrast helps, and we are using IVUS, and that is obviously helping us as well. So now we are taking a scoring balloon. So a scoring balloon, you can take a scoring or a cutting balloon at this point of
Yes.
time. Now that you've created
After
a
rota,
lever
now we can also use cutting balloon or scoring balloon.
as well. So we're taking we're taking the scoring balloon. So this is the NC scoring balloon, and as you can see, the balloon is going quite easily.
2.5.
Before this, even I was calculating. So the rota has obviously done a very good work.
This
And as you can
2.5 balloon.
2.75 by 10.
27510.
Now here the issue also is that it's a left dominant system. So the right. So now we went up to 18 atmospheric pressure. Yes. So right. So we can now have a look with the IVUS if you want to, or we can.
Madam, I have a query, Madam. Bijoy.
Yes, please.
Madam, can you hear me?
Yes, I can hear you. How are you, Bijoy? Nice to hear you.
Madam, do you recommend scoring balloon or cutting balloon in every cases of rota, or when you use scoring or cutting balloon before or after rota?
The thing is, you have to remember that we have to prepare the lesion well. We don't want a stent under expansion or difficulty during stent delivery or stent malposition. So for that reason, you have to prepare your lesion very well. And in many instances, it is the operator's choice. Some operators prefer cutting balloon, some operators prefer scoring balloon. So it's there's no hard and fast rule. So you can do whatever suits you. So today we decided to take a scoring balloon. So we haven't used much dye, as you appreciate. So now we're dealing with the diagonal. We're doing gentle pre-dilatation there.
This is a bifurcation lesion. Whether it is a double stent techniques, madam.
You know, nowadays we always try to do provisional, and we usually do not go for upfront double stent technique unless it's absolutely necessary. And another thing that we have found that helps us really, that if there's good TIMI flow after pre-dilatation, using a drug-coated balloon is also a very good option.
You want to go stepwise professional.
I want to go stepwise professionally.
Yes.
Yes. So now we are taking our IVUS catheter for the LAD, and let's have a look of what we have done. So as you can see, we used a 1.5 rota bar and we went for very long lesion preparation. After that, we proceeded to use a NC scoring balloon, a 2.75 by 10 millimeter balloon that we went up to even 1820 atmospheric pressure. We have not as yet used much dye. Now we are taking our IVUS catheter. Can you give me that? Yeah.
Ms. Jamal sir,
Yes.
whether we can take single stent technique here, we can think about of single stent strategy only in the LED in this bifurcation lesion.
Yes, so now the IVERS, we're taking our IVERS
Re-
done.
regarding
Uh,
regarding bifurcation lesion, though in the morning I have told, though we are till now lacking a clean-cut definition of complex bifurcation and simple bifurcation, still there is, according to definition to criteria, 1-2 criteria. In this case, as far as possible, if we plan for single stent strategy, professional stent strategy, that is, I think, better. And if necessary, second stent we will consider as per the clinical scenario. And if the side branch for non-left main side branch occlusion after doing this angioplasty to the main vessel is more than 75%, or TIMI flow is impaired, or there is significant TIMI flow impairment as well as clinical presentation or ECG changes, only then we can treat the side branch. That is also initially with KBI, and if it does not complete the procedure, meaning that side branch is still jeopardized, then consider for second stent strategy. As you know, in EBC main trial, only 20% required second stent and 80% did not require second stent.
I think particularly
Mr.
for
Jamal,
this
sir.
case,
Yes.
this is not a acute coronary syndrome and stable coronary artery disease, and patient is having CKD with anemia, elderly patients. So I think we should be keeping on very simple strategy here, and I think single stent strategy would be the
And other thing
the
that is
preferred
important,
one.
if you go to the reference angiogram, there is lesion in the LED just after ostium. So lesion in the diagonal just after ostium. Diagonal ostium was perfectly normal. So the lesion was in the diagonal, but not that is at the level of ostium. So it is not a true bifurcation.
Ostium is healthy.
Ostium was healthy.
Healthy,
Yes,
that-
yes. Another thing, that patient got blood transfusion yesterday. 65 years old.
Right.
And CKD patient. We have to think about the dual antiplatelet for long term. So bifurcation is very much difficult to stop dual antiplatelet even after 1 year.
We like to hear from Guzman.
Yes, sir.
What is your strategy if this case is in your lab?
Yeah, so clearly there is a calcified lesion in a patient with chronic kidney disease. So when you see a calcified lesion with chronic kidney disease, you know that you need to do some debulking. I do not think that there was a balloon patient from the get-go. I think there was a rotational atherectomy from the get-go. I do not think that IVL is an alternative in this patient because the length of the lesion is very, very long. So I do believe that this was either a CSI atherectomy or rotational atherectomy from the get-go. I would have not done a balloon. So it is a bifurcation for the LAD, but I do agree that the ostium of the diagonal branch does not appear to be involved in the LAD lesion, so I would go for provisional. However, this patient has a long diffuse disease proximal diagonal branch. So if you are going to treat the diagonal branch, which appears to be the case because you decided to balloon the diagonal branch, otherwise I would have not ballooned the diagonal branch, probably I would have done the LAD to see whether there is a appropriate result. And if it's not an appropriate result, then I would have do a second stent from the ostium and probably a T configuration. Personally, I would have not treated the diagonal branch. I would have treated the LAD only. Personally, I would have not ballooned the diagonal branch because now that you balloon the diagonal branch, you are committed that you need to treat that diagonal branch. There is no way that you are not going to treat it. I am concerned that that balloon in the diagonal branch didn't look to me that open all the way. So you might need to do some kind of some kind of ablation therapy there. And regarding the size of the rotational atherectomy, I want to remind you that what we are doing here is trying to change the morphology of the plaque. We are not trying to get an excellent result with the rotational atherectomy. We're just trying to modify the plaque in order to allow us to deliver the stent properly. So regarding the dual antiplatelet therapy, I do not think that this patient.
Yes, I was no, yes, live stream.
I'm sorry.
as
So
we are-
regarding the dual antiplatelet therapy, I do not think that you want to do long dual antiplatelet therapy in this patient. I think he is a very high risk for bleeding, anemia, chronic renal insufficiency. I think this is as short as possible, and probably I would have used for a month dual antiplatelet therapy, and after that I would have used a single agent, ticagrelor or prasugrel as a single agent for 6 months and then reassess at that point.
Dr. Guzman.
Okay, as we are running short of time, we need to go back on screen. Madam, what progress you have made so far? Please let us know.
LED crossover stenting.
Yeah.
She is doing. Dr. Guzman, what is your practice for provisional stenting? Whether you touch side branch before stenting or not?
I am a proponent of provisional stenting as a concept. In most bifurcation, there might be someone that I will go with double stent, but in general, I know that we have a Dr. Chen coming here, maybe challenge me, but or I don't know if he's coming or not. Yeah, so, but I'm not a DK crash proponent as a double stent for all. I am a provisional stent person for most, and in some will be a double stent, but in a provisional fashion.
Madam,
Thank you for the input. I just wanted to go that we did an IVERS run after our this scoring balloon, and you can go to the IVERS, and we saw that we had managed to crack the calcium quite a bit, and we also identified our landing zone and the diameter of the stent. So proximally, the vessel is around 4 millimeters in diameter. In distal, it's around 2.75. And so we decided to take a 3x38 synergy stent. We positioned it at the ostia of the LED, and we've deployed our stent. We've kept a wire in the diagonal. Now we plan to do post dilatation. At the proximal, we'll be using a 4 millimeter NC balloon, go up to high pressures, do post dilatation of the entire length of the stent, remove the wire for the diagonal, have a final IVERS, and that's us done. Let's go to live picture again. So we've deployed our stent, positioning it from the ostia as we knew that is where to position. The length that we had received from our IVERS knowledge was that it would be a 34 millimeter. The healthy landing zone we identified. So imaging really helps you guide you what you want to do in a complex case like this. And So I think we'll get rid of the diagonal wire if required. This is 4x14 NC balloon.
NC balloon.
Yes. We've hardly used any dye, as you can appreciate. How much dye have we used so far? So we've used around 25 ml of dye, and So now we are just pulling the LED wire, and hopefully we will be able to cross into the diagonal. Once we do that, we'll take the diagonal jailed wire and go into the LED. We'll do our final post dilatation and take a final shoot and an IVERS. So let's see whether this wire is a bit sort of broken, so we might need a micro to go into the diagonal. Yes, I think we'll be needing a micro because this wire is quite. taking a fine force microcatheter over this wire, and maybe I would need to change the wire itself.
Madam, what were you were using for crossing the side branch now?
Oh, it's a run-through wire. The run-through wire that was present in the LED.
So you are recrossing the side branch, sir, madam. No.
Yes, that is the plan. I think we might need to change this wire. This wire is
After post dilatation, whether the side
Will
runs
you-
where can be
will
trapped.
Appa, will you show us after stenting as well as post dilatation at least 2 ml dye? What is the clinical scenario? What is the angiographic result?
That's mandatory. We'll definitely do that. We have to take a final shoot. I mean, even if it's an ultra low contrast or whatever, you need to take a final angiographic shoot. That is absolutely. We might need a hydrophilic wire. Let's see how things go. So we rewire the diagonal. Let's see. And we are sure that we're in the lumen because this was the wire that we got from the LED. Now we'll pull back the jailed wire from the diagonal and we'll put it in the LED. And then we'll do some it's very tightly jailed, as you can appreciate. Now we'll do post dilatation. So we'll take for the proximal, we'll again post dilate with the 4 millimeter because we pulled the jailed wire from the diagonal. We want our struts to be absolutely aligned to the vessel. For the distal part, we'll take a 3 millimeter NC balloon. And then after post dilatation, we'll just do an IVUS run and a final angiographic shot. So if anyone wants to see the hemodynamics, touch wood, the hemodynamics have been good so far. She has tolerated this procedure and we had to do it because her angina was really bad, and you can appreciate the amount of angina she must have been suffering because the disease burden was huge, and obviously considering her CKD, her frailty and her anemia, she was not a very good surgical candidate. So this is us going with a 4 millimeter. Now we'll take the 3 millimeter balloon. So we're up to the carina, right, of the diagonal and the LED. And we go up to 12, 14 with the 4.
For the younger colleagues, to recross in the side branch, withdrawing the LED wire is good, excellent, but not for all, not for the day one. As because if during withdrawal you come within the guide and once again you want to enter into the side branch, you may go behind the stand, though optimized. Even then there may be chance, and that is why for the younger colleagues it is a bit risky to withdraw the main vessel wire. To me, I keep the main vessel wire up to the last work and give another wire. If third wire you can use, and after third wire, using third wire, then you withdraw the second wire in the side branch. For the younger colleagues, I like this
That's a very great
practice.
suggestion. Yes, I personally
For
also
I told for the
doing
younger
that.
colleagues.
You're right. That's what you should be doing.
As because in this year they have shown in Europe this year what they have done, withdrawing the main vessel wire and inadvertently going behind the start and inflating the balloon, making the disaster.
Can we do a stand width? Yes, a stand width, please. So we'll do a stand width, and after that we'll do an Ivers run and then a final angiogram. Ready, Kone? Ready, Hone? Stand width, please. So you can see the struts nicely open in the stand widths. No, so now we'll do a final angiographic shot and then a final Ivers.
Yes.
So as the pressure is quite all right, we'll give a good amount of nitro to open up the vessel, and then we'll take a angiographic shot. Yes. So the diagonal looks fine. We don't plan to do anything for the diagonal, and we'll now take a final Ivers run and we'll call it a day. Ivers. This is the lady, right?
Take two now. Proximal part.
You think we need further post-dilatation in the proximal part? If required, we'll definitely do that. But we went up with 4 millimeter stent, went up to 20 millimeter atmosphere. And Synergy is a very good stent where, you know, there's a mismatch in size between the proximal and the distal part. You can adjust your stent to the proximal part, which we did. So we have taken a 3 millimeter by 38 Synergy, and for the proximal part we went up to this 20 atmospheric pressure. So let's see how the final result. Angiographically it looks good.
Yes.
Touch wood. So a final Ivers, just to see whether we need further optimization of our result. And I think that's what imaging does, right? It guides you in what tools to use in the pre-procedure. It allows you to choose your tools well, your stent and everything. And it also allows you
at least 3 times necessary. After
so now
doing procedure and after.
taking an Ivers run, can someone show the Ivers, please? So we don't have any edge dissection. Our stent is well opposed. There's apparently no malapposition up till now. The stent is well open.
আসে না এখনো।
And this is a very calcified vessel. I think we got a very satisfactory result considering the extent of calcium that we had to deal with. It's quite a long run. And now we're in the left main. So I think positioning and stent position wise we're good. And I think we can call it a day. And the distal also there's no edge dissection, it's well open. And initially when we had a minimal luminary of 1.3 in the tightest portion where we could not pass our IVUS catheter after that. Now it's all open and nice. So that's us done. Thank you so much for giving us this opportunity of presenting this rather complex case. And if you want, we can do a final ileocaudal. We've just used like what 30 ml up till now. If you want, we can do a final ileocaudal or we can close this case.
Okay, thank you, madam, for your nicely done and precisely done case in a patient with high bleeding risk and CKD and anemia. So as we are running short of time, we will have some brief comments. First of all, from the chairperson, Professor Eqm Reza. Please.
Thank you very much. I must thank Professor Fazila Malik to doing the challenging case. You know that the calcium, preparing the calcified segment of a artery is very crucial before stenting. If we have do not do the proper preparation of the calcified vessel, then there may be a very suboptimal result. So this case very nicely done, but the side branch I have a bit confused that madam dilate that side branch before stenting. I think it is not very mandatory for dilating the side branch if we consider that this will be done by provisional stenting. Thank you very much. Thank you again.
Professor Sabina Hashim, we will have the concluding remarks from Professor Mir Jamaluddin. Professor Sabina Hashim, please brief comments.
It was a very complex case, done very in a very simple manner, and rota ablation was done very nicely. And one thing, the patient had got CKD, so madam has reduced the amount of dye very less, and she used very less dye, and the result was very nice. Thank you, madam, for a nice case.
Dr. Abdullah Jamil, please brief comments from you.
Thank you very much. Fazilapa demonstrated an excellent case and very severely calcified LAD. And for the beginners, for rota ablation, probably this kind of straight vessel is better for rota ablation. And also, this patient had subintimal calcification more than the medial or adventitial. And this is the ideal case for rota ablation. Thank you, madam, for a nice presentation.
Professor Mustafa Jaman, brief comments from you.
Thank you, Professor Fazila madam. Actually did a tremendous case and a step-by-step demonstration of this type of complex case, how to perform. Okay. Actually, this has increased our learning curve, and she did always like this, and we have learned many things from her every time, every year, and always. And I have a question, because this type of lesion, when I recross the wire in the side branch, in suppose bifurcation lesion in GK crash or some cases, there may be importance of when it recross the diagonal, the first start or last stent start, third stent start, have any importance of stent start during crossing the side branch or diagonal? Maybe this is first or last. I have a question. This this type of lesion have any importance of recrossing of side branch wire?
Madam, would you like to make some final comments before we conclude? Actually, we have two more discussants to make their comments.
So about the side branch here, actually, as it was a provisional stenting, the strut that we crossed was not really that important. But of course, if it's a GK crash, you go through the proximal strut, and if it's a culotte or a tab that you're considering, you go through the distal strut. That's the customary practice, I believe, yes.
Thank you, madam. Dr. Mahbubur Rahman, very brief comments, please.
Thank you, Professor Fazila Malik, for demonstrating very nice case. I think the two things, beauty of this procedure are two things. Number one is the minimal use of contrast media, optimized using of IFAS, and the single stent strategy for this case. It's very nice. Thank you.
Dr. Vijay Datta.
Thank you, madam, for doing a nice case. The learning point is that the scoring balloon and the cutting balloon can be used in different settings, in different situations over rota, as you have already mentioned, and the use of minimum die. And I have a query, madam, that okay, and that's all.
Professor Mir Jamal, please, your concluding remarks, please.
Thank you, Professor Fazila Malik, for your brilliant case. Already Dr. Mahbub told several beauties of this case. In addition, I like to tell another beauty, that is also a bifurcation lesion. Meaning that in a case of severely calcified lesion, there is bifurcation lesion, doing with rota with ultra low contrast is an excellent work, and for this excellent work we must have to give a good clap for her and for the Department of Cardiology, National Heart Foundation Hospital and Research Institute, especially for Professor Fazila Malik. You are our asset and you have shown very nicely. We are grateful to you. Thank you, the SKY organizer.
Thank you, Fazila Madam. We believe less is more, so we should appreciate your approach.